days. And this is great news. However, there is a significant cost of cure. So childhood cancer survivors are at high risk for chronic illnesses and late effects when they reach adulthood. And I'm going to be using the term late effects. And late effects are really side effects that occur more than 5 years after treatment. So they're not present when somebody first finishes treatment. And these risks are so high, they're variable depending on studies, but in a recent study, by 40 years of age, 98% of all survivors had developed a chronic disease by the age of 40, and 80% had developed a serious or disabling life-threatening condition. And what's important to know about late effects is that the risks actually increase with age. So they increase as a person reaches young adulthood, middle adulthood, and then later adulthood. And there are numerous different late effects that result from the specific therapies that people have. So first off, individuals are at high risk for second cancers. And this is largely due to radiation therapy. So for example, a woman who's had chest radiation to treat Hodgkin's lymphoma has a 30-fold increased risk of developing breast cancer compared to the general population. Individuals are also at high risk for organ dysfunction depending on the therapy that they had. So they can have cardiac, endocrine, pulmonary dysfunction as a result of the certain chemotherapeutics or radiation therapy that was in that area. Individuals also can have impaired growth and development as a result of radiation therapy. When you think about a child compared to an adult who's had radiation therapy, a child's tissues and whatnot are still developing, so that interferes with normal growth and development. If you look at the photo of the two gentlemen standing side by side, this is actually a picture of twins. And the individual on the left had craniospinal radiation therapy, which markedly decreased, stunted his growth and his normal musculoskeletal progression. Individuals are also at high risk for neurocognitive dysfunction depending on the therapy that they've had. And this can contribute to difficulties with communication, with attention, memory, and which can also interfere with normal psychosocial development. So childhood cancer survivors, although many of them do very well, a subpopulation is at higher risk for depression, PTSD, and things like lower educational attainment and lower marriage rates. So there are a number of very different late effects that individuals are at risk for. And considering these high risks, a number of European and North American organizations now recommend that all individuals have access to long-term follow-up, and that this long-term follow-up ought to include, at the very minimum, screening for recurrence and secondary cancers, as well as surveillance and treatment of physical, but also psychosocial late effects. The reality, though, is that when you look at the evidence around late effects and around providing services for late effects, there really is limited evidence that describes survivors' perspectives and their experiences of their health challenges and how they go about managing their late effects. And it's my opinion that survivor perspectives are absolutely essential if we want to develop patient-centered services. And that's so that survivors, but also healthcare professionals, can actually prevent, detect, and manage the numerous late effects that individuals are at risk for.
Yusha, it's Jennifer. I'm just going to interrupt for a second because your voice is coming in and out a little bit. So if you can just make sure you're close to the microphone. Thanks.
Okay. Is that any better?
Yeah, it's good. It just seems like maybe you're moving away from the microphone and then closer. So.
Okay. So the research objective in this study was to provide an in-depth description of the different ways that adult survivors of childhood cancer manage their medical, but also their psychosocial challenges. And in this research, we used one theoretical lens, and that's relational autonomy. And what relational autonomy does is it draws attention to how individuals are embedded within their relationships. And it draws attention to how relationships as well as organizations and social context can shape an individual's agency or their ability to manage their health or to self-manage or to get other people involved in their health care. So, for example, it helped us to explore how survivors' interpersonal relationships either helped or hindered their management of their late effects. Now, this was a qualitative study, and it was a narrative inquiry, it's a specific type of qualitative research. And in narrative inquiry, we consider stories and how stories are used by individuals to make sense of their experiences. And the emphasis in narrative inquiry isn't in parsing out themes right away, it's in keeping individual stories intact. So the emphasis is on the individual rather than themes throughout in the initial stages. So the research we did was conducted in British Columbia with individuals who were diagnosed before they were 19, but who are now older than 19 years of age. So they were currently adults. And we recruited through 2 BC clinics, through website and Facebook. And as the study progressed, we used purposeful sampling to try to represent a number of different individuals with different diagnoses, as well as areas of where they were living and different socio-demographics. We conducted 30 in-depth open-ended interviews with survivors, and in keeping with narrative analysis, we considered each survivor's transcript as a whole, and then we constructed a summary, a narrative summary for each survivor, and we compared and contrasted these narrative summaries. And then at the end, we constructed what we called meta-summaries for each of the main narrative themes that we found. So the individuals that we interviewed ranged in age from 20 to 43 years of age. 30% lived outside of Vancouver. The majority were single, had completed some university or college, and were employed. About a third were diagnosed before the age of 4, about a third were diagnosed between 5 and 9 years of age, and the other 40% were diagnosed before the age of 10. So our group represented a range and a variety of different cancers, and almost all had received chemotherapy and radiation therapy. So what's important to note is that because most of these individuals had received radiation therapy, they were actually at higher risk for late effects than the general population of childhood cancer survivors. And you can see that is reflected in the late effects that were self-reported by survivors. So we didn't look at their medical reports. We asked them to self-report the late effects that they were experiencing or had been diagnosed with that they were aware of. So the most common self-reported late effects were impaired growth and development and musculoskeletal challenges. It's important to note that almost 40% had experienced or were experiencing anxiety or depression. And then about another third of our sample had learning difficulties or cognitive impairment. A third had experienced a second cancer. A third had impaired sexual development or infertility. And about another third had endocrine late effects. And then there were a number of other late effects reported by our survivors. So we originally had asked about health and social challenges and how individuals manage. But what we found was individuals, the survivors that we talked to, spoke a lot about social isolation and the difficulties they were having in their social lives. So this was right off the bat. And so we decided to do a sub-analysis looking at social isolation among adult survivors of childhood cancer. And what we found was that social isolation is not, in fact, a static thing, that it evolves over time as individuals age through adolescence and then young adulthood. And we identified 3 different trajectories of social isolation. The first was diminishing, so it got somewhat better. The second was persistent, it never got better. And then the third was delayed social isolation, so it hit individuals later on. And I'll just go through these 3 trajectories quite quickly. So in diminishing social isolation, these individuals were very socially socially isolated after school and after treatment. So when treatment finished, they had difficulty making friends, and they had experienced extreme bullying. They were self-conscious of their appearance. You know, they had lost their hair, some had gained weight, some looked different when they came back from treatment. And individuals with learning disabilities felt overwhelmed, and they also felt that their learning disabilities and the accommodations that were made, in fact, contributed to their social isolation. And that's because they were physically isolated for special assistance, and it contributed to them feeling even more different than they'd had from their peers before. These individuals felt, though, that their social life had actually improved relative to school. They had a few friends, and they had meaningful relationships with a couple people. Although they had improvements, though, social difficulties often lingered, and this contributed to a number of individuals expressing that they experienced depression and loneliness, specifically related to feeling socially isolated. And some individuals turned to substance abuse in order to forget about their problems or to overcome their shyness. Because things had gotten somewhat better for these individuals, they were optimistic about their future. They wanted to put cancer in their past, and they were tired of complaining about their problems. Then there were the group of individuals who felt that things never got better. So, like the first group, they experienced bullying right after treatment, but these individuals perceived that their social development, so their ability to socialize, was interrupted. They experienced that they had impaired capacity in functioning in social situations, and they felt that their learning disabilities had made them a target by their peers, and that they were ridiculed for their learning disabilities. However, for these individuals, their social isolation defined their current social life. So they had limited meaningful relationships. They were unable to make new relationships, and this was because they felt they had impaired social functioning, but also social exclusion. There weren't those opportunities to make new connections. And for these individuals, depression and loneliness were pervasive, and they desperately wanted more fulfilling future social life. As one brain tumor survivor said, "I'd pretty much do anything. I'm willing to do anything, but no one invites me out anywhere." And so the third trajectory of social isolation was a bit of a surprise. This was the group who had done very well after treatment. They'd formed close relationships and considered their social lives to be normal. But when they entered young adulthood, they experienced difficulties reaching normal milestones, for example, going to university or being in relationships or having children, and they felt that they were left behind by their friends, who were increasingly occupied by other things, such as work and family. And these individuals felt that their late effects limited their ability to engage in social activities. For example, individuals who had hearing difficulties said that it was very difficult for them to operate normally in large groups or in noisy settings, so they would avoid those types of settings. And these individuals were beginning to feel that intimate relationships were going to be out of reach for them. And because of that, they were uncertain about their future, and they were losing hope that life would turn out as they had expected it would. As one leukemia survivor said, "It's hard because all my friends are working and starting families, and I don't see that in my future anymore. It is tough because I think all little girls think of that in their future. Well, I try not to think about it too often." So that was the sub-analysis we did on social isolation. I'll turn now to how individuals themselves felt that they managed their health. And the first thing that we found was that late effects, both physical and emotional and social, were unexpected and they were unresolved. And because they were unexpected, they were largely distressing for individuals. As one individual said, "I didn't really understand the risk. I just suddenly had all these problems, and it was a big shock my thyroid, then my breast, and then ultimately the infertility. What was interesting, though, was that survivors who told us that they had been informed of their risk when they were younger were still surprised when it actually developed, when it became personal to them. And these late effects they framed as unresolved because many of the issues that we're experiencing were actually chronic diseases because of limited treatment. And they recognized, or they were starting to recognize that many of the risks that they had, they would have for the rest of their lives. They would be lifetime risks. So in this research, we identified 5 different narrative themes that really described the different ways that individuals manage their health. The first was trying to forget. In this one, survivors, these were narratives that were short, they were devoid of details, and they ended very quickly. So survivors, in using this narrative, they ignored and they rejected their late effects and their risks. They presented themselves in the interviews as just like their peers, and they didn't want their late effects to interfere with their normal life. These individuals also described engaging in risk-taking behaviors that they knew were not good for them because they really desperately wanted to fit in with their peers. And the different strategies that they used to forget about cancer included avoiding any reminders of late effects. So they didn't go to the doctor, they avoided hospitals. They also disengaged from individuals who would remind them of their health. So when parents would bring up, the fact that they should go for a checkup, or that, it seemed like they were fatigued, they would disengage from their parents. They also didn't want to have anything to do with other peers or other cancer survivors because that was a reminder of their cancer. And different strategies that individuals used to forget also included substance abuse, things like gaming and self-mutilation, identified by 2 survivors. So the constructed summary for this narrative is as follows. Being a cancer survivor has no impact on anything. I just live a normal life. I have virtually no medical issues. I just forget about these things. The last thing I want to do is relive that horror. I routinely miss appointments. I avoid doctors. Those things, late effects and risks, are not worth worrying about. So in the next narrative, Trusting the System, the survivors acknowledged their late effects and the risks, but they really focused on moving on with their lives. As such, they left the responsibility of managing their health and their risks to other people, namely healthcare professionals and their parents. So they trusted that they were being looked after by the healthcare system and by their healthcare professionals. They expected that their parents would continue to coordinate with the healthcare system, for example, scheduling appointments, reminders, whatnot. And they didn't seek out any additional care or information, even when they started to experience late effects. As one survivor said, when I'm listening to the doctors, they use big words. I don't know what you're talking about, but keep going. I'll catch up in a minute. I'll see if I can get it, which for the most part, I can't. The danger for these individuals was that if the medical system fails, which we know it often does, they may not receive the appropriate care. The constructed summary for this narrative is as follows. I simply accept my medical follow-up as one of the consequences of my cancer. My regular checkups are just routine. I have testing done every 2 or 3 or 5 years because she, the doctor, wants me to. I have faith in my oncologist and GP, and I put my life in their hands. I just rely on what they say. So moving on to the third narrative, this is kind of the opposite of the last one, being proactive about my health. These individuals expressed significant anxiety to their existing health problems, but they were also very worried about their potential future health problems. These individuals, a number of them had been lost to follow-up for a significant period of time, and they had experienced difficulty learning to access and navigate the adult healthcare system. Unfortunately, these individuals shared a number of experiences where they had seen healthcare professionals who were naive or who were dismissive of their risks or the symptoms they were experiencing. As one individual explained, "I explained to the dentist in great detail that my dental problems are from the radiation, but he was still convinced that they were a result of eating too much sugar." So because these individuals had significant anxiety, and because they had already experienced difficulty with the health care system, they themselves became expert patients, and they framed their difficult experiences as a call to action. So they became very knowledgeable about their health and knowledgeable about their health risks. They became very active in managing their complex health challenges. A number of them had made their own files. They kept copies of everything. But these individuals also recognized and told stories about the worry that they witnessed among their parents. And because of that, they downplayed their medical challenges when they were interacting with their parents as a measure of protecting their parents. So in many ways, they took charge of their own health and protected their parents from having any involvement in managing their health. So the constructed summary for this narrative is, "At first I was lost, no one was looking out for my health. Now I'm very proactive and persistent. I'm informed, I have all my documentation, I can get a second opinion, I can get access to resources, and I know what to keep an eye on. I don't see my life without these small and maybe one day big health challenges." So moving on, the fourth narrative was stumbling from one problem to the next. So in these interviews, survivors, they expressed a deep sense of despair that the late effects that they had and that they were experiencing would continue, and that others would arise down the road. They felt that because of their late effects, they had no choice but to trust multiple healthcare professionals, and that's largely because their health issues were so complex that they were unable to self-manage. They also felt that the chronicity of the late effects that they had experienced over a number of years was absolutely emotionally exhausting. And in these interviews, the stories of psychosocial late effects dominated. And that's because individuals felt that the physical late effects that they had experienced had really contributed to feelings of loneliness, depression, anxiety, but also difficulties with getting a job, having relationships with others. And they also felt that any services and support that they had accessed up to this point were often ineffective, and in some cases, because they were ineffective, this was demoralizing, and they were losing hope for the future. These individuals described significant travel, time, and financial costs associated with their medical care. And because of this, individuals were beginning to forgo care. These individuals also told difficult stories of feeling abandoned or unsupported by their parents, who could no longer be there to support them like they did when they were children. The constructed summary for this narrative is as follows. Cancer has always continued. It's tough not being able to identify what is causing these problems or what we can do to lessen the impact on my day-to-day life. Not being able to see any improvement in anything. Depression and social isolation have been constant. I don't get any answers or support. My parents are not there for me. I don't know whether I have another 30 years. So moving on now to the last narrative, this narrative was struggling to find my way. These stories were very disjointed, they were angry, and they were chaotic. And they're stories about debilitating late effects that ruled survivors' everyday life. These individuals talked about really struggling to comprehend medical information. These individuals, many of them had insight into their neurocognitive impairments, but that insight, rather than empower them, in some instances, contributed to poor self-confidence and a limited perceived agency. they shared a number of stories where they felt that healthcare professionals were condescending or were uncaring, and it was this uncaring nature of relationships that was the most hurtful. These individuals felt that they were unable to manage independently their complex healthcare needs. They felt that they were lost when they were expected by others to manage their care. What was interesting, though, was that although they were unable to manage independently, they desperately wanted to try, and they wanted to be supported to manage independently. And in many instances, they felt resentment when they were forced to rely on others rather than to be supported. The constructive summary for this narrative is as follows. I still get double vision, my hearing is dropping, my balance is off, and I have slow motor skills. I use wrong words, I have slow thinking. The childhood doctors can't help me because I'm an adult, and I hate adult doctors. I worry about what will happen. I don't want my dad there. I want to be independent. I want to be happy, but I don't know what that is. I'm just coping with life. So in conclusion, from both studies, we can see that a lack of counseling to assist survivors to cope with the risks is a barrier to engaging in follow-up. Also that there's limited support to assist survivors with chronic impairments, so complex chronic impairments, to really make sense of their experiences and help them to put it into the context of their lives. We also found that there's a dynamic tension between survivors' desire for independence, they're young adults now, but also their lingering need for parental assistance and support when it comes to managing their health. We found, not surprisingly, and been found in a number of other studies, that healthcare providers have limited knowledge, but that this limited knowledge can act as a barrier to basic late effects prevention and management, even when individuals are connected with the healthcare system. We also found that a lack of empathy and understanding, or perceived empathy and understanding by healthcare professionals, can undermine the provider-survivor relationship and can lead to survivors disengaging from the healthcare system. We also found that at the time that this study was being done, and historically, that there's limited processes that enable survivors to transition to adult services. So a number of survivors, and I know this is the case across the country, have been lost to follow-up. And that really psychological and social supports are insufficient. In terms of implications, I think we can do a better job of educating healthcare professionals about late effects, and that a system for providing lifelong services that are tailored to really the complex and often chronic needs of childhood cancer survivors is needed. And I know in BC there's been a lot of work done in the last couple of years. In terms of practice, I think that personalized medical care must include approaches that engage survivors and that help them in self-management, that help them to improve not just their physical late effects, but also their quality of life. And that's especially in the cases where there isn't treatment available for late effects. So we need to help survivors to cope and to live with the long-term consequences of treatment. And there's a lot of research that needs to be done in terms of interventions to help to empower survivors to engage with the healthcare system. And there's been a lot of research in the area of survivorship care plans and whatnot, but I think there needs to be a lot more in terms of engaging in survivors who are at different points in the trajectory of survivorship. And lastly, that psychosocial supports and interventions are desperately needed. So I'll stop there. I tried to leave quite a bit of time for questions and comments and discussion, so I welcome your input.